You probably realize I tend to be repetitious, over things over and over again. These are a few slides on the ear. Um, well, we're looking at the external ear, and can be called the auricle or the pinna. Sometimes it's good to have nomenclature, at least in your mind, even if you don't use it. The area in front of the ear is called the preauricular area. So if you see something and they describe it in the preauricular area, that's how they use to describe the area in front of the ear. And behind the ear is the postauricular area. Rather than front or back, they'll use those terms. The area below the ear, traditionally going back many years, they referred to that as the infraparotid area, because the parotid gland is right there underneath the skin. You don't realize that because it's sort of a flat structure, and it's right there. It wraps around behind the ear. It has a little tail and a body, so that area is called the infraparotid area. Common sense would tell us that if you have someone who may not have any complaints but has some particular break in the integrity of the skin, well, you always have to think of cutaneous cancers. Squamous cell cancers of the external ear are more common than basal cell cancers. But then again, you might just have a bit of inflamed actinic keratotic manifestations. They don't all have to be cutaneous cancers, but always want to be mindful of that. And they'll occur along the helix of the ear, right along the rim of the ear. There's another condition that it's not uncommon and that you should be aware of. Usually in older people, they'll have an ear that they say is real painful, particularly when they lay down on it. And there is a condition called nodular chondrodermatitis, right on the edge of the ear, kind of up here. And you'll look at it and you'll see a little raised bump. You'll feel it. They'll say, oh, that's painful. And they notice it if they lay in bed and they press on that. It's not any form of atypical cutaneous cancers, and it remains unexplained. It's called nodular chondrodermatitis of the helix of the ear. They don't like any pressure put on it. And surprisingly, one of the best things to do when they sleep is to put a corn pad. It's got a hollow center over that so they can rest. And then usually after a while it'll fade away. It may take weeks. And then they'll still have a little knot there, but it won't be painful. It's just in nature. It's not uncommon. You'll see it in older people. Now, I show this slide because I think I have said this so often people get kind of sick of it. Before picking up any instrument to look at the ear, whether it's the microscopes that I use or an otoscope or any tool, you have to ask those three questions. And what are those questions? Are you having pain, discharge, or drop in hearing? You'd have a rule. I never look at an ear until I find out if there's pain, if there's discharge, or if there's a drop in hearing. And once you have that, then you have some guide as to what you're going to maybe see in the ear. But if you don't ask those three questions, you're looking in the ear and you say, oh, gee, I can't see diddly in this ear. But if you establish those three things, pain, discharge, or drop in hearing, now someone usually will correct me and say, no, wait a second, you forgot the fourth condition, and that is, are you having rotational vertigo, which is part of the vestibule of the ear. The reason I admit that, because if you use that word dizziness or vertigo, then they'll get off way on another subject that might have nothing to do with their primary concern. So I don't use that, unless they're specifically telling us about it. Now I use this diagram because it actually appeared in some material that came from our Ear, Nose, and Throat Academy. It's a simple illustration that they put in a little flyer. And I show this because it shows that even someone who has approval of the Academy to make a drawing makes some real errors. Now the error here is that you never see an ear canal that has the same dimension throughout. All ears have a narrow segment in the middle, some more than others. Every ear has somewhat of a anterior canal wall bulge. You know, it might be slight, but it's always there. Well, the artist didn't draw that, so that's a mistake. The other mistake that the artist made is that he made a concave eardrum, but the eardrum always has a tilt to it. That point there should have been illustrated out here. It shows you that sometimes things get approval without a bit of misinformation. That is a poor drawing. It's not narrow and it doesn't have a tilt on it. That might work better than my finger. Now this is a picture of an ear taken through the microscope, and I show that because this is an ideal ear. You don't see anything in it. The skin is thin, and you can see the blood vessels on the skin, which you should be able to see. It does point out this anterior canal wall bulge right there. So technically, you can't see all 4 quadrants of the eardrum. The eardrum has 4 quadrants. You can't see the anterior inferior quadrant. Sometimes that frustrates providers trying to help or answer some questions that someone has. You rarely can see all 4 quadrants perfectly because of the anterior canal wall bulge, and then that fact that it's slightly tilted. So ahead of this bulge, you have what is called the sulcus. It drops down into a little area there, and sometimes debris can get trapped in there. You may not even see it. This is a picture of a very normal ear. You might say, well, it doesn't look healthy to me. It looks like it's a discoloration. Another feature that you want to remember, the color of the ear can vary from one person to the other, but it's, again, the story that they tell you. Are you having pain, drainage, or a drop in hearing? This happens to be a normal ear taken with colored film at a certain speed, and it shows up as normal. The other thing that you can see here in a normal, you can see the incus, malleus, the incus, and you can see that little structure above the incus, which is called the chordae tympani nerve. And that's a very healthy looking ear. Now I'm often asked the question, what about the light reflex? You see the light reflex in this photograph. The light reflex is meaningless. The color of the ear is what's important. Now they pick up the light reflex because of the way this picture was taken, but to say you have to see a light reflex when you look at an ear is wrong. You're looking at the concerns that the patient have and the color of the tympanic membrane, if that's the area of concern. This ear shows no cerumen, which is not something that you very often see, but you can see an ear that doesn't form cerumen. It's a very healthy looking ear. Here again, this is just an illustration to show the various quadrants. You'll never see the entire eardrum like this. You're either the anterior superior quadrant or the posterior inferior, anterior or inferior quadrants. On anterior you may not see. But in a real healthy ear, sometimes you'll see a little segment of the incus coming down. And as I showed on the other side, the chordae tympani nerve. Now, here's something that's not uncommon. Someone is totally asymptomatic, you might look at their ear, and what do you see? You see these little knots. They're called bony exostoses. Sometimes there's one, sometimes there's several. And they don't interfere with hearing, and they don't necessarily interfere with the way skin naturally desquamates and dead skin cells come out of the ear. They're usually relatively close to the tympanic membrane, but never exactly against the tympanic membrane. You may not see it. You may just see one. You may see several. You might see it on one side. You don't see it on the other. It's the only cause of this is people who do a lot of swimming in cold water, and they get this osteitis, and then they'll get these little bone projections, and they'll usually stop growing after a certain dimension of growth. But technically, if an individual were to continually swim in extremely cold water for long periods of time, you can get quite a large number of these little bony knots. And that's why it's sometimes called surfer's disease of the ear. People who surf all the time.
Why cold water?
Because of the fact that it must have some effect on the, see, there's skin here, and then there's nothing below the skin, so the bone is exposed to something that is cold, and then they say it excites this osteitis, which is, yes, you have skin here and you have a little bit of periosteum, but not a lot. And they think that's the reason why the bone starts to grow a little bit.
Is this redness up here anything? Like it just looks kind of red?
Yeah, it's just a little bit of earwax that we see there. Now, this is an ear just filled with debris. And so this patient may complain of fullness and lack of hearing, may not have any drainage from the ear. We could spend all day talking about the proper way to remove debris from the earwax. And I don't have any magic solution. Assuming this is entirely cerumen, we know that there's an excessive formation and the ear is not cleaning itself. 90% of ears, maybe 95%, are self-cleaning. They form cerumen, and it is formed in the distal part of the ear canal, as you know, and it dries and fragments out of the ear. Don't really have to do anything because it's truly made by Lord in such a way that it self-cleans itself. But there's some that don't. So how do you remove earwax? Well, I'm sure if we ask that question to people here, we'd all have different answers. Should we irrigate the ear? Should you use something to soften up the ear? Should you stop at Walmart's and buy a Demarco? Should you use peroxide at home? I don't know if I have the answer. I do think that if it appears to be just cerumen and there's no inflammation and the patient is complaining of fullness, there's certainly nothing wrong with making an attempt to irrigate the ear with a little bit of slightly warm water. Obviously, we all know we shouldn't use cold water, then stimulates the vestibular part of the labyrinth and causing people to feel vertiginous. The question is, how many attempts should I make with warm water to remove earwax? Well, if it's done gently, you can do it, 2 or 3 times. I wouldn't use a lot of force. Are eardrums broken with a lot of water pressure? They certainly are. You can rupture the eardrum if you use too much water pressure from your syringe. I think the rule of thumb is stop when there's discomfort. If you make a couple attempts, there's no discomfort, and there's still fullness in there, just don't do anything. You might have them attempt to soak it with some baby oil. I'm not a great peroxide fan. And then come back to try again. If you try again and it's not successful, then someone should look at it with magnification just to be sure there's not something preventing this material from being expelled from the ear. This isn't the best illustration, but there are some people who form a lot of wax and dead skin, and it tends to dip down into a little bit of a valley, and they end up with a plug of dead skin in a small little area in the inferior part of the ear canal, and it's not uncommon. It's called keratosis obturans. It's like an obturator of dead skin that fits into a little groove, usually in the bottom of the ear, and those are the ones you just simply can't wash out. The water will never penetrate below these layers of skin to remove that. It's not uncommon. You don't see it in young people, but you'll see it in some people, maybe 35, 45 and older. And we don't know why it happens, but skin sheds, instead of coming out in little fragments, it sheds in layers, and it just layers upon itself. And then it creates, just because of pressure, a defect in the bone. So you have a bony defect, there's all these layers of dead skin in there. It's called keratosis obturans. And that has to be removed with the microscope. You have to gently get below that and get that material out. We've had people that have had keratosis obturans for years. The eardrum is the ear totally occluded. We have to anesthetize the ear to get all that dead skin out of there. You can't prevent it except having them come back about every 6 months and then using a little baby oil ahead of time so that you can get that debris out of there. It's not an uncommon condition. I'm sure, well, here in the pasta, I should make a note of next time we have one to show one of the students or one of the providers of keratosis obturans.
How do you feel about Demarco?
I'm not a fan of it. I'm just not, because I look at the debris in the ear differently, and because I can use a microscope. I'm not saying there's anything wrong with it. I'm not saying there's anything wrong with it. It will tend to loosen up skin to the point where you might be able to wash it out, but I don't routinely have them use Demarco. I don't. Some people say, I use it frequently and I see many patients and it works fine. That's fine. Nothing wrong with that.
Would you say it's wrong to, I've heard people say, like, in the shower, if you have, like, a stream, like almost letting the actual stream hit that and like letting that water go in your shower is okay?
I would avoid that.
Okay.
I would. If you do that consistently, sooner or later you'll end up with an otitis externa. It's going to be a matter of time. It may take a year, it may take 2 years, but if the skin of the ear is constantly wet, it cannot shed dead skin cells and come out naturally. You end up with an inflamed bit of skin. It doesn't propel material out. And the other thing is that an ear canal that's always wet is vulnerable to organisms that get in there. There's no protective attempt to control that.
So really, real quick, we stopped doing irrigations now here at our clinic. And I'm honestly a lot because I learned so much from Dr. Demarco along these lines. Because we used to do the irrigations, and after each irrigation, I would have to end up giving them Ciprodex because
Essentially the protective qualities of the
right.
ear canal.
So I mean, you have to kind of stop and think. Okay, so we irrigated their ear, and now we have to give them a Ciprodex because we just beat up that ear canal so badly. And I know everybody does it in the emergency rooms. We all do it elsewhere, but I highly recommend against it now because I think the better way to clear out an ear canal is to literally have the wax, the excess wax pulled out. Wax is not bad in itself. Wax is there as a static, right? I'm supposed to say static, not bactericidal, but a bacteriostatic material that the body naturally produces to keep the ear canal, you know, with a normal bacterial flora.
And then you told them before too, patients to use anything instead of water, oil-based. Like you told them, I think even one, like even canola oil or something.
Yeah, any oil.
oil-based
Yeah, it's
that
neutral
they
to
have
the
even
skin.
at home.
Oil is essentially neutral to the skin, and it
Just
may
you
soften some
drops
debris
it
on the
in,
surface.
helps
Is what
soften
it's
and
doing.
drops and I get it out naturally.
You want to continue? Or
No, I
Yeah,
just wanted to
that's
add to
fine.
what you were saying because I think it's important for primary care because honestly, going through my family medicine rotation, they taught me to do irrigations.
Yeah.
And they did
Water
too,
pick
yeah.
and
And I agree with Dr. Demarco now. Looking back at that, it's actually a pretty traumatic procedure that doesn't need to be done.
You make someone dizzy though as you're going in there
And-
with the water and then they get this spinning sensation.
vertigo.
Well, here's something we saw just the other day. I think a couple of the students. This is an individual that, are you having any pain? No, but my ear seems to itch at times, and I'm getting a lot of dead debris out of the ear. I suppose the dermatology people would classify this differently. It's usually bilateral, and you look in the ear and you see this chronic desquamated debris, not necessarily deep in the ear canal, but right at the opening, maybe going in a few millimeters. And usually people that are a little bit older, and they complain of the ear not necessarily being painful, but somewhat itchy. If there's a lot of debris in it, they'll complain of fullness. Now, I classify this as just a localized eczema of the ear. And these people often don't form proper earwax or none at all. They don't have a lot of sebaceous secreting glands in the conchal of the ear, so they have weak skin. And as a result, the ear tends to be scaly and itchy, and they frequently go in there and scratch it. I think we saw that yesterday with the students that were here. And now sometimes you get a lot of shower water in the ear, which again I would be opposed to that. These individuals do quite well if you have them keep the ear meticulously dry and to use a low potency steroid because they're going to be using it periodically for many, many months, maybe the rest of their life when their ear itches. And it'll usually quiet down, the ear will not be as scaly and as itchy. They use a little bit of topical triamcinolone, the lowest potency that you can have them use. and use it at least once a day, maybe at night before going to bed, and the ear will generally settle down. As I was telling the student the other day, if you do that and they come back and the ear still doesn't look like it's completely resolved, then you don't want to overlook the fact that you can be fooled by fungus. Can sometimes present this way. You can have this scaly, weak skin that harbors a certain amount of surface fungus debris, and then in that case I would use something that combines one of the antifungals with a little steroid. The one that we use, the trade name is Lotrazone. It seems to work for it.
For just over the counter hydrocortisone, could you just use like the 1% if
Yeah.
you're using it long
You
term?
can use 1%. Low potency, as you all know, if you start using these high potency cortisone preparations, because it's just going to be chronic, you're going to end up thinning the skin more and more and more and more. You're weakening the skin. But 0.1% triamcinolone generally won't do that.
So this is something that's just inside of the canal
Just
then?
well, in this little area which we call the conchal area, sometimes
Right.
you'll see it up in the little cracks in these little areas called the scaphoid fossa and underneath the tragus. And sometimes you'll see it behind the ear in the postauricular crease. I describe it as a form of eczema, usually not anywhere else in their body as a rule. But you don't want to be fooled by people who have significant scalp seborrhea that affects their ear. Then you can be fooled. I think the gentleman we had yesterday, we specifically checked his scalp. He doesn't have it up there as well.
Do you see this with patients with like psoriasis that usually complain of like the itchy ears?
It's
and
mainly
they'll have-
psoriasis might be elsewhere in the body. It's not frequently in the ear canal or in the conchal area, and I can't explain that.
Huh.
It isn't that it wouldn't occur there, but it's not a common complaint.
Yeah.
Not in the ear. Now, this is a picture of, mentioned just a moment ago. You look in the ear and you see debris. Now that technically might be able to be washed out. It's going to come back again because this is truly fungal otitis externa. You see it there. It's old-fashioned fungus, probably one of the Candida species.
Are you looking at the lighter portion, lighter colored
This
portion?
whole area here is just a big fungus mass. You can't see the tympanic
Oh,
membrane.
gotcha, yeah.
This whole area there.
Yeah.
And what they complain of are two things. They complain, I can't hear, and my ear is so become itchy, and it's been going on for a long time. And it doesn't have to be bilateral. It can be just in one ear. This comes about because the integrity of the skin of the ear, always remember that the first layer of the eardrum is skin, and then the entire ear canal. For some reason, the natural protective process of this skin is lost. And then, as I often say, the ear canal is a perfect place for organisms to live and fungus to live because it's dark, it's warm, and if it's moist, you're going to have fungus. It's going to grow in there. And sometimes the tip-off is that it'll be aspergillus. It'll be all this black debris. And people have even told us, they washed out my ear and I felt so much better because I could hear, but I noticed in the dish there was a lot of black particles. They washed out all the fungal debris that was aspergillus. And then these people say, I felt good for a week, and then it fills up again. Well, obviously, fungus will grow right back. How to treat this? Well, everyone has their own philosophies. I guess you learn as you get older not to be fooled too many times. And I really chase this very vigorously. I'll clean all this out, and I'll just fill the ear entirely filled, clear to the outside, even into the conchal area, of just plain old Lotramin. Just fill it full. And it blocks the ear. And they'll say, well, I came in with a blocked ear. I'm leaving with the blocked ear. And then you say, well, we know that. We want you back in about 10, 14 days. And then you look in the ear, and either it's worked well or it hasn't. You might still see a few little colonies of fungus, and it can happen. Then I would clean all that out and I'd fill it full again. But even if it takes 2 or 3 or 4 visits, Lotramin is still a good standard to use to clear up fungus. But you might have to really chase it. I happen to chase it very vigorously. I just fill the blessed thing up. Because even one little colony that you might miss, even if I use a scope at 10 power, if I miss one colony of fungus, it'll grow back again. It will return. After that, then we have in the routine, we'll tell them how important it is not to use any water of any sort. That's why, getting a lot of water in the shower, you shouldn't do that. You're going to invite the environment in there for possibly fungus to grow. And then sometimes you'll give them a little antifungal cream to use whenever the ear is itchy to control the onset of any future fungus colonies that might grow in the ear. There's a lot written about this in diabetes. There's no connection. In all of the many years I've seen people with fungus just say, well, you've got fungus because you're a diabetic and you're not under proper control, your blood sugars are sky high. No connection. Not from the ear. Now, there may be other cutaneous manifestation of fungus, but not in the ear. To say the two always go together, uncontrolled diabetes and fungal otitis externa, there's no connection in my mind. Clinically, it's not something we see.
So that's a condition that will not clear up on its own, correct?
Nope.
When you fill it too, do you just have them keep a cotton ball in place until they see you in 10 days?
No, I'll just fill it full so they can even see it. And I tell them, don't wipe it out, just leave it there.
Leave it. Okay.
And draw some attention at home. Just tell them you just fill the ear up, leave it alone.
Just a little bit.
Could you just place a cotton ball and even a little paper tape, just if they felt like they wanted to, I don't know.
Oh, protect it if they didn't want people to
Yeah.
see it, they could do that. The reason I do that is because you could have a few little fungal colonies in the conchal area of the ear, and you're going to cover all of that. I wouldn't make it excessive. I'd fill it full, I wouldn't let it just drip out of the ear or anything like that. I really go after it.
Because I'm thinking on a warm day, once that cream gets a little warm, it might start oozing.
You
Yeah.
could. And that's fine if they see a little bit of it trickling out. They can wipe that away. But it's interesting, at least the typical Lotrimin, after it's exposed to the air, it tends to congeal. So when they come back to see you in a week or two, you'll look in there, you'll say, all that white paste I put in there before using Lotrimin is now sort of receded, and I just see a few little clumps, because it tends to have that effect. In terms of time, it tends to dry out. It sort of dehydrates, if there's such a word that you can use for a compound in pharmacy. It tends to dehydrate and form that mound of material. Now here's our old friend. A person comes in with acute pain, acute ear pain. Very, very common. I think we've talked about this before. Very common condition. Once again, before looking at the ear, you said, do you have pain? Oh, I have terrible pain. I didn't sleep last night. Can you hear? Oh, I still can hear some. Do you have any drainage? Oh, maybe minimal. And when did it start? Oh, just three or 4 days ago. Where were you at? They might have been swimming somewhere. Possibly. Not always. That's why it's called swimmer's ear. But the tip-off is real pain. People with acute otitis externa, swimmer's ear, almost, I'd say 90% tell you they didn't sleep the night before they saw you in the morning. The pain is really significant. And that is why I often mention these people sometimes are seen in the emergency room. They're told they have swimmer's ear. They're given an oral antibiotic, which may or may not be appropriate. They're given expensive ear drops. They're not given any pain medication. So they say, well, I got this medicine, but I didn't sleep worth a hoot. And these people do require pain medication. Even if we tend to be very judicious about narcotics, I think a few are in order, and they don't sleep well with this at all. Now, of course, when we see them, we have the advantage of looking in the ear under a microscope, trying to clean out any debris, and then putting a wick in. And you can do that even on your own with, they have these manufactured little wicks that you can use, and we just fashion a little slip of cotton and slip it in there, because if you use drops in the canal, there's occluded, the drops aren't going to go anywhere. They won't go anywhere near near this inflamed skin. You just put a pre-made wick or a long slip of cotton down there. At least that cotton can act as sort of a highway to get drops further down in there. Now the question is, what kind of drops should you use? Some drops are extremely expensive, very expensive. Ciprodex, I wouldn't even know what it costs. I happen to go back to a very simple eardrop that's been around. It's called cortisporin suspension. It uses the generic cortisporin suspension. It's cheap. You can't use it if people are sensitive to neomycin, but it works. It's effective if you have a wick in place.
The eye drops though, because you can use the eye drop version of this, it's way cheaper, so you can use the eye drops always on ears, right, but never the eardrops on the eyes, is the way that it works with like the different brands that are out
Or
there, so it cuts down
the high
cost.
potency steroid ones.
And it cuts down the cost almost in half, so if you ever have a patient that just has a super high deductible plan.
Do those
or,
are those
you know, pharmacy benefits.
just the tobramycin or the erythromycin ones? Because there's not a Cipro one,
There's
the
a
eye drop,
Cipro.
is there?
Yeah,
Okay.
yeah, and so you can use that one, the eye one on the ears, but you can never use the ear
Ear one
one
of the eyes, got it.
for the eyes.
They're, they can be effective, but I think they're too expensive, and you don't have to necessarily use them in the ear.
How do you know for sure if you need a wick? Is it only when it's like so swollen
If
that
you
it looks
can't
closed?
see, if you can't see the ear, it needs a wick.
Okay.
You can't see in there.
Do you ever put them on the oral antibiotic and the drops if it gets to that point where they have so much swelling?
And that's a good place to continue. There's some people that need oral antibiotics, and my tip-off is if it's acute otitis externa, it's painful, and you don't see any soft tissue inflammation of the auricle itself, either in the conchal area, preauricularly, or in the auricle, I won't give them antibiotics. But if you do, you say, oh gee, there's a little bit of swelling here in the tragus, I can see that, and it looks like on this the crus of the helix, it's inflamed, this conchal area seems full, or the ear itself just looks inflamed, then you want to put them on not only oral antibiotics, but a short course of steroids. You really should.
What causes the inflammation that you're seeing there? What is it that actually causes that?
It's a break of the skin integrity. Everyone's skin is remarkably tolerant. It's remarkably tolerant, as long as it doesn't get wet. And cerumen is very protective. It prevents bacteria from. Proper cerumen is remarkably acidic, and it prevents bacteria from growing in the ear. There's no doubt about it. But if the ear is frequently wet and they don't have good protection from cerumen,